Welcome to Mayo Clinic Sleep Medicine Podcasts, a series for physicians, advanced practice providers, nurses, and other health practitioners treating sleep disorders or interested in learning about state-of-the-art advances in sleep medicine and sleep health. I'm your host, Dr. Michael Silber.
And I'm your co-host, Dr. Maitri Juna. We are both consultants at the Center for Sleep Medicine at the Mayo Clinic in Rochester, Minnesota.
Snoring is common in children, and sleep apnea is overlooked by many pediatric providers. To discuss the diagnosis and management of obstructive sleep apnea in children, my guest today is Dr. Julie Baughn, a board-certified pediatrician and sleep specialist at Mayo Clinic in Rochester, Minnesota. Julie, thank you for coming on today. When you are referred a child who is snoring, what additional features on history or examination do you inquire about to determine whether you think the child likely has obstructive sleep apnea rather than some benign, pure snoring?
Thank you so much for having me today. Some of the features we look for is how frequently are they snoring. If they're snoring more than 3 nights a week, that's a flag to kind of do some further investigation. Are they mouth breathing at night? We should breathe through our nose at night. So mouth breathing at night is something to be aware of. Are they moving around a lot in their sleep? Are they doing any what we call airway protective maneuvers? So are they sleeping with their mouth open and their neck extended or sleeping on their tummy? Do they have any daytime sleepiness? And in kids, daytime sleepiness they can seem tired. They can maybe nap when they have given up naps, but it can also manifest itself with hyperactivity and having trouble paying attention in school and behavior issues.
Okay, so that's very helpful. So those are somewhat different things from we as adult sleep specialists would look for.
Yep.
Julie, you were a member of the American Academy of Sleep Medicine Task Force in 2017, which concluded that home sleep apnea tests were at that point not appropriate for the diagnosis of sleep apnea in children. Now, as I understand it, this recommendation remains the same 8 years later. The majority of adults, as you know, with uncomplicated sleep apnea are now diagnosed by home sleep apnea tests. And we know that laboratory polysomnography is expensive and it's stressful for children and stressful for their parents sometimes. So, with all the advances in diagnostic technology, why are we still recommending laboratory studies for routine sleep apnea in children?
That's a great question, Mike. I think that the literature is being reviewed to see if that
Mhm.
recommendation should be changed. However, I don't. One of the issues is there are many different devices out there, and they all use different technology. So, knowing which device would be good at picking up sleep apnea in children is challenging. Sleep apnea in children is a little bit different than adults, as we've already discussed. We don't have a great clinical way to know which children snore or have a high pretest probability of sleep apnea like you do in adults. Adults, the home sleep apnea test is designed to diagnose moderate to severe sleep apnea. And in children, moderate to severe sleep apnea often comes with a much lower AHI than it does in adults. So knowing kind of what will pick up on those signals is a challenge, and we still lack a lot of comparison to the gold standard in the literature to know what is going to be an accurate test for our children, which is really important because first line therapy for children is getting those tonsils and adenoids out, and so we want to make an accurate diagnosis so we're putting the correct children through a surgery.
Have studies been done comparing it? I mean, you said there's going to be a new
Yeah.
task force. Are there actually studies out there suggesting that really there isn't anything which would be accurate enough?
I mean, the studies that are out there are usually pretty small sample
Mm.
sizes and have had mixed results so far.
Right. Good. Okay. Well, we look forward to hearing the new recommendations if they are changed. So you mentioned that it's a little different measuring them in adults from children. So remind us how the criteria for mild, moderate, and severe sleep apnea differ in children from those of adults.
Yeah, so in children, an obstructive apnea-hypopnea index greater than 1 is considered abnormal. Between 1 and 5 is considered mild sleep apnea. Greater than 5 is moderate. Between 5 and 10 is moderate obstructive sleep apnea, and greater than 10 is considered severe. We're also encouraged to look at other factors during the child's sleep to determine severity, and that includes the degree of desaturation, increased work of breathing, and airway protective maneuvers. As we've discussed, kids can really contort their bodies into positions to open up their airway, and they're more prone to partial airway obstruction and prolonged partial airway obstruction than actual apnea events.
Okay, so really for adult sleep specialists, that's a very different set of criteria. It's important for
Absolutely.
everybody working in sleep medicine to be definitely aware of that. So, as you mentioned, adenotonsillectomy is the first line therapy for most children with OSA. So, let's talk a little bit about it in 2025. I mean, the procedure's been around forever, but hopefully
Yeah.
we're better at doing it now. So, first question would be, do children have to stay in hospital, or is it an outpatient procedure? And what are the risks? Because that's the first thing I would imagine parents are going to ask you.
Yeah, so some children will need to stay overnight. Many children will be treated in an outpatient fashion. So children who are younger, definitely less than 2, will spend the night just because they are a higher risk of complication.
Mhm.
Or if there's severe sleep apnea prior to surgery noted on a sleep study, then those children will stay overnight. The main risk factor is going to be there may be some respiratory difficulty post-operatively, and that is most likely, again, if someone comes in at a young age or with a more severe sleep apnea prior to surgery. And then bleeding is the next most common risk, either at the time of surgery or within the first 2 weeks of surgery, when that eschar or scab can kind of fall off and cause bleeding. And obviously bleeding in the throat is a concerning thing. So those are kind of the main risk factors. Um, yeah, and tonsillectomy used to be done very commonly, as we're kind of all aware of, and very frequently for children. It's getting more and more guidelines on tonsillectomy are getting more and more conservative. The guidelines for um, is like 7 strep throats in a year, or the diagnosis of obstructive sleep apnea are the 2 main indications now for getting those tonsils out.
Well, some of those complications sound a little scary. I mean,
Yeah,
I just had a new grandchild, and is it a grandfather or
yeah.
as a parent, you hear the bleeding in the throat, respiratory compromise. I presume
Mhm.
these are rare, and the vast
Very,
majority of
very low.
children just sail through the procedure. That's
Absolutely. Hmm.
okay. So how effective is it? And I suppose a follow-up question would be, under what circumstances do you restudy children after to find out if it was effective, or do you just judge it symptomatically?
Yeah, great question. So about 80% of the time, it's going to be effective at taking care of sleep apnea. So most typical children who have sleep apnea that's mild to moderate and have enlarged tonsils, that sleep apnea is going to be taken care of with the surgery, the tonsillectomy. We do restudy a certain subset of children, particularly those who have more disease prior to surgery. So definitely moderate to severe disease before surgery, or if they have some risk factors to have residual sleep apnea after surgery. So if they're overweight or obese, if they have a syndrome like Down syndrome, trisomy 21, that has a high risk of sleep apnea throughout the lifetime, some other syndromes like Prader-Willi or neuromuscular disease, we will restudy those children after. But most children don't need to, and will have their sleep apnea taken care of.
Okay, so let's say you go over this with the parents and they say, I don't want this. I
Mhm,
don't want my children. I've read it up. Tonsils are necessary for immunity or whatever. I don't like
mhm.
the risks. I don't want my child to have surgery. What conservative therapies are available as alternatives? And I suppose this leading out from that, the parents are going to ask you, will they outgrow this? I mean, do I have to treat
Mhm.
this at all? Do they outgrow it as they get older?
Yeah. So there were the 2013 CHAT study, which was the randomized controlled trial that randomized a certain set of children to a watchful waiting and a certain set of children to early adenotonsillectomy, showed that up to 40% of children can outgrow this within 6 months. Now, we don't have longer term follow-up beyond that to know if these children then got sleep apnea again. But definitely watchful waiting, particularly if there's not a lot of daytime symptoms. And if the sleep apnea is mild, is very reasonable, but follow-up is needed to make sure that things get better with time. And then there was another study that looked at a smaller group of children that were the younger age group. The CHAT trial was children age 5 to 9, and the other trial looked at a younger age children, and those children also a high percentage outgrew in about 6 months. And again, we don't have kind of follow-up data beyond that. So definitely an option. Other options include what we call anti-inflammatory therapy. It's off-label use of intranasal fluticasone or montelukast to decrease some inflammation in the nose, and that's an option. And children can certainly use CPAP, and we do have children on CPAP. Most of the time, those children have had their tonsils and adenoids out first, but that is an option, particularly if the tonsils aren't real big.
Mm-hmm. Okay, and then what about other surgical techniques? Are
Mhm.
there other things apart from tonsillectomy and adenoidectomy that may be helpful in a subset of children with sleep apnea?
Yeah, very, very unusual, but it can happen. Sometimes getting those lingual tonsils out, particularly in children with Down syndrome, can be helpful. Um, sometimes children need another adenoidectomy. The adenoids can sometimes regrow, so sometimes that's an option. A certain small subset of children, and particularly young children and infants who have laryngomalacia, benefit from a supraglottoplasty to treat obstructive sleep apnea that is associated from their laryngomalacia. And then there are, occasionally they can try in children who are very hard to treat some of the other surgical techniques. Those are not well studied in children, and so knowing outcomes is quite a bit of a challenge. And then in children with Down syndrome, we now have the option to use hypoglossal nerve stimulation, which is a really amazing kind of breakthrough for that population that has a lot of obstructive sleep apnea through its lifetime, and can be very challenging to treat with PAP therapy.
There's some jaw procedures that have sometimes been recommended.
Yeah, so
Remark-
yeah, and thanks for bringing that up. So some infants with Pierre-Robin syndrome or micrognathia can have mandibular distraction in the infancy that can also treat their sleep apnea.
Okay. Now, one more question. We've been talking about children. Do all these things apply to adolescents? Where's the cutoff when we say
Mhm.
change the criteria from pediatric definitions of mild, moderate, severe into adult? What's a reasonable cutoff if you're a physician seeing somebody who's 15 or 17 or just turned 18? When do we apply
Mhm.
adult criteria as opposed to pediatric criteria?
Yeah, great question. So according to the scoring ASM scoring manual, we can do that anytime after the age of 13, and can use adult criteria between 13 and 18. It's really at the discretion of the sleep provider. My personal approach is to use pediatric criteria until they're 18, but I interpret the sleep study results within the context of their age. So an 17 or 18-year-old who has an AHI of 4 and meets pediatric criteria for obstructive sleep apnea, I'm probably not recommending that they use PAP for that, because it is pretty mild. But that's kind of my approach. But anyone above 13 can technically be scored using adult criteria. Now, with the new hypopnea rules, which include the new hypopnea rules for adults, which are 3% desaturation or arousal, really match the pediatric hypopnea rules now too. So it's a little bit less of a difference, I would say, in how you score them.
Oh, that's important to know. Thank you.
Yeah.
Well, thank you so much for sharing your expertise. Are there any final messages you'd like to leave for our listeners who are predominantly sleep medicine providers, but maybe also for healthcare providers who don't specialize specifically in sleep medicine?
Yeah, I think, one thing about pediatric sleep apnea that's really important to know is that, again, kids aren't often, especially adolescents, they're not showing a lot of daytime sleepiness. It's more that hyperactivity and attention issues. So if you
Mhm.
have a child, particularly if their sleep apnea has been treated or if it's in that mild range and they are showing daytime sleepiness, significant daytime sleepiness, continue to pursue maybe some of those other sleep diagnoses, such as does this child need an evaluation for narcolepsy? Is this child getting enough sleep at night? Does this child have a circadian rhythm disorder? Because again, it's pretty unusual for children to be falling asleep during school because of their sleep apnea.
Oh, good. Thank you so much.
Thank you for having me. It's a pleasure.
We hope you enjoyed this podcast. If so, please tune in again through wherever you receive your podcasts as we discuss further topics in sleep medicine and sleep health. Thank you.